Welcome, everyone. Looks like a lot of folks are away for the holidays, but for those of us that are here, we are going to have a really educational and excellent presentation by Dr. Kandie George, who is one of our neonatologists, has been here at Kapiolani for several years now, and has really done an amazing job of growing and developing the palliative care program in the NICU, where, of course, there are matters of life and death every single day. But for those of us like me who are not in the NICU, still lots of really important principles that she's going to talk to us about as far as how we can think about, the best decision making that we can guide our families towards in difficult situations. And I'm really looking forward to learning from you, Dr. George. During the course of the talk, I will be looking in the chat, and so we'll interrupt if there are clarification questions or things like that. And then otherwise, if there's time for some conversation at the end, we can also talk about either difficult cases that folks have had or any other questions that people might have. So Dr. George, go ahead. I'll mute myself and I'll just interrupt you if there's pressing questions in the chat.
Awesome. I am so honored to be here. Thank you so much for inviting me. And I promise that this will have relevance. I don't expect anybody to be like, well, I want to be a neonatologist after this or want to do palliative care medicine. So I will try to make it as relevant as possible. And please ask as many questions. Because I am not very tech savvy, I thought this will have been easier. I am trying to share my screen and I have a map. And it is blocking the share screen for the first time. And I'm not sure why. So I'm pressing share, desktop. And it is not opening. So
try now to change the settings.
Oh, that's what it's asking me to do. I am not very good at it says open system preferences, and then I open, now it's just not allowing.
Do you want to try one more time? Because I changed it so you should be able to share screen.
Oh, okay. I am all about trying another time. Okay, let's try. It is still giving me some problems with the system settings.
Is it easier if we just ask Summer to share for you?
Let me pull it up.
Apologize. Let me try. While you pull it up, I'll try again.
Okay.
In the meantime, does anybody have any questions before I start? Like in terms of concurrent care, anyone has experienced any patients on concurrent care, or what perinatal palliative care have you ever experienced? Had any experiences?
I certainly have. As a hospitalist, we've had several patients that are on concurrent care, and that is something that's really wonderful and unique to pediatrics, and at least here, that makes things so much more manageable for our families. One thing I would love to ask about too, and maybe you address this during your talk, but I have found that in general, I think it's part of American culture and culture here as well, that people are very afraid of talking about palliative care. In my own personal experience, my 95-year-old grandmother was admitted to hospital for like the first time in her life. And within 3 days went from being independent at home to not being able to walk. And nobody mentioned palliative care until I asked for a consult. And I feel like that's even more so the case with children, because children aren't supposed to die or have life-limiting illnesses. And yet for me as a hospitalist, for you as a neonatologist, we certainly see it quite often. And for everyone else from time to time, it's still going to come up. So that how to address that fear that blocks people from providing needed services in a really compassionate and kind way would be something that I would be really interested in talking about.
Beautiful. I'm glad that you brought that up. So I'll make sure that I address that. So welcome everybody. I'm Kandie George, as introduced. Next slide, please. I have no financial relationships with any companies, eligible or ineligible, in the last 24 months. And my objectives were already stated, so we'll move on. So to start, we're going to start with a poll question because I love to involve everybody. Please be honest. What percentage of women who choose to continue their pregnancy knowing their fetus has been diagnosed with a life-limiting condition did not regret their decision to do so after the birth of their child? All right.
Sorry.
Oh, the poll. Yeah, I get it.
We can run the poll at the end all together. I didn't make it separately.
No problem.
Yeah.
That's okay. So we'll leave that question for now. The answer will come soon. But I'm just curious, for anybody on the chat, like, do you mind taking a gander as to A, B, C, or D? I see someone in the chat. Lenise says C. Oh, Dr. Pamela says C. Grace says D. Okay, love it. We have a little bit of diversity of answers, so I do love that. Thank you for those who answered. Next slide, please. All right, so let's first make ensure that everybody understands the definitions of what we're going to discuss today. So perinatal is defined as a 22 completed weeks gestation through to 7 days after birth. That's what we describe perinatal as, the ICD-10 definition. And the WHO defines a neonate as any child under the age of 28 days of life. So this is where I think a lot of us have problems. And Maya, you are not the only person. When you mention palliative care to parents, they run for the hills, right? And that is, and it's something we see in the NICU. It's something we see when it is that their OB says, okay, well, we're going to refer you to the neonatologist who does palliative care. And the parents are like, no, we don't want to terminate this pregnancy. Because what palliative care was traditionally focused on was pain management, advanced care planning, and discussions of end-of-life wishes. And sometimes when I go to these large palliative care symposiums, a lot of the physicians are like, do you have your advanced care planning? And I'm like, oh my God, I'm only 40. So, you know, that is the focus, especially in adult medicine. But when we talk about children, palliative care for a fetus, a neonate, or an infant with a life-limiting condition is an active and total approach to care. From the point of diagnosis, and that means in utero, when that mom gets that diagnosis that there's everything is not right, or recognition throughout the child's life on the pediatric floors in oncology, at the time of death and beyond. It embraces physical, emotional, social, and spiritual elements and focuses on the enhancement of quality of life for the neonatal infant and support for the family. It includes the management of distressing symptoms, the provision of short breaks, and care through death and bereavement. So what palliative care is we are just a layer of support. We are not the death squad, which a lot of times previously, that is what our role was, right? Talking about end-of-life care and pain management and advanced care planning. What do you want if it is that this treatment doesn't work? What we're here to do is we're here to really walk the path with that family as they go through their journey. Palliative care in the perinatal period is what that focuses not only on the fetus, but rather the maternal fetal diet is what we define perinatal palliative care as. Goals and plans of care are uniquely tailored to the needs of each, the mother and the fetus. Pregnant women whose fetus has been diagnosed with a serious medical condition could benefit from guidance, shared decision-making, and really and truly just compassionate care throughout the remainder of their pregnancy, from the time of diagnosis to birth of the infant and beyond. And what I mean by this is, at 18 weeks, a mom goes, everything, she gets pregnant, and happy, right? Maybe it's her 10th round of IVF. And she's like, yes, we finally did it. Everything has come through. Things look, finally, life is looking up. At her 18-week ultrasound, she's sitting there and the sonographer is doing the ultrasound. And as much as we think in medicine, we have the best poker faces, we are not very good. So she could already tell, mom can tell that something is wrong because the ultrasonographer face has changed. Then when she goes to say, the mother says, is something wrong? The ultrasonographer is like, no, she didn't say no. They say he or she says, let me get the doctor. So then the mom sits there already thinking, oh my God, what's wrong? And then the worst possible news is delivered to her and her partner that the pregnancy that she's been looking for is not perfect. What do you think is the first thing that these families do when it is that they leave the doctor's office? Anybody? Take a guess.
Google.
Google, thank you. And you know what? We are not as up to date as we think as to the shifting climate. Next slide. So trisomy 18 and trisomy 13. How many people in their practice when we were practicing residency and whether you did a fellowship, how many people were told that these babies just die? Some of them don't make it to birth, and those who do don't live long lives. How many of us have been told that? Well, you know what? When I Google trisomy 18 survivors, which that mom or that dad or that grandma or that auntie would Google, these are the kids that we're seeing. The overall incidence of serious birth defects has remained unchanged. It's not that we're getting more trisomy 18s, more trisomy 13s, more osteogenesis imperfecta. However, over the last decade, medical knowledge regarding prognosis and management of serious congenital conditions has expanded. Therapies have extended life expectancy by weeks, months, or even years for serious congenital conditions that were, until recently, regarded as uniformly lethal. So what do we know? There's expansion of fetal diagnostic evaluation during pregnancy, widespread ultrasonography, and a lot of you have been hearing about this NIPT test, right? This non-invasive test. You don't have to do amnio or choreo anymore. You can just go ahead and take a blood test from mom, and you can diagnose some genetic conditions. So that has led to increased diagnosis of a lot of congenital conditions. And then what has it done? Well, we felt that we did so good in medicine, right? Now the parent knows, well, you know what it does? From 18 weeks to the time of birth, all we've done is cause emotional distress of the family. They have now become information seeking, difficult, and now they have to make difficult decisions and prepare to give birth to and care for a child who will go on to have significant medical needs or may require careful, thought out, individualized comfort care measures. So the goals of perinatal palliative care, or just palliative care in general, is that we want an interdisciplinary team approach. And we want to make the family the center of our approach. We want to communicate well, and we want to plan goals of care specific to that family's individual, emotional, spiritual, and cultural needs. And I want to specify to everyone that just because you're Chukis doesn't mean that you follow all Chukis customs. So we should not say blanket cultural needs, so every individual is same in that cultural bracket. No. Perinatal palliative care, we are not here. Our aim is to affirm life and acknowledge dying as a normal part of life. We are to provide a support system to help the family cope and navigate through what would undoubtedly be one of the worst life experiences. Next slide. What are we not here to do? Well, sometimes we get consulted palliative care, whether it be on the floor or in the PICU. We get consulted or prenatally to pursue termination of the pregnancy, right? We try to persuade the parents to pursue termination or opt for comfort care measures for their child. That's what people think that our job is. Like, oh, well, this is going to be a lethal anomaly, or this baby's going to have disability. Could you come and try to persuade this parent? That is not what our goal is. Or this family on the floor doesn't realize that this kid is going to have significant disability. Why do everything? We're not here to help parents choose between treatment or palliative care. And that's where concurrent care comes in, outpatient. Because what we do is we get to let parents choose curative measures as well as be followed and be supported by the palliative care team. We are not here to hasten or postpone death either. So the answer was D, and I think one person gave us that answer. And I will tell you, just remember that on the floor, I know you have your complex patients and you think to yourself, this mom must have known this baby had this syndrome or this. Why did she continue her pregnancy? Why? 97% of women do not regret their decision. Next slide. Annie Javier published a paper in Pediatrics in 2012. And why I'm focusing on trisomy 13s and 18s, you'll have different syndromes on the floor that you deal with that are considered lethal or disabling. But I chose this because it's a hot topic, trisomy 13s and 18s. And she looked at the experience of families in social networks. She surveyed parents of children with trisomy 13 and 18 who belong to support groups. A total of 503 invitations to participate were sent and 332 questionnaires were completed. Next slide. Parents reported being told that their child was incompatible with life, would live a life of suffering, would be a vegetable. I can't believe some of us would say that, but it is said. Would ruin their family. Their child might have a short, meaningful life. Next slide. 30% of parents requested full intervention as a plan of care, knowing that their child had trisomy 13 and 18. 79% of these children with full 13 and 18, meaning not mosaic, are still living. The median age, 4 years. These are the kids we were told will die. 50% of parents reported that taking care of a disabled child was harder than they expected. Despite their severe disabilities, 97% of parents describe their child as a happy child. I would encourage you guys to read an article called Pepperoni, Pizza, and Sex. And it was another article, it was an article written by Annie Javier, the same Annie Javier. And she wrote about her experience in the NICU as a neonatologist. She was taking care of a 27-week baby, and the baby had made a turn for the worse in the NICU and wasn't doing well. And I'm pretty sure you can relate to some cases on the floor and the PICU. So when she was sitting with this young family and discussing, oh, your baby's not doing well, and trying to see if it is that comfort care, maybe comfort focused care, maybe a shift in care that they may consider, the father surprised her and asked, will we be able to love him? Another, I think it was the mom asked, will he be able to love us? And then to any physician horror, the father asked, will he be able to have sex? And then another question posed to the physician was, would he be able to put pepperoni on a pizza? Quick, that's a strange question. I could understand the others, but that took the neonatologist a little bit aback. And she asked them to explain. This family, this young couple, belonged to a larger family that owned a pizza parlor. And in that pizza parlor, there was already a cousin, I believe, that had a disability. And all that cousin who did, because everybody worked in the pizza parlor, all of the family, all he did was put pepperoni on a pizza. That's all he did. He used to put the pepperoni on the pizza. And they thought that he was a happy child doing that. So they asked if their son would be able to do that and also be happy. Why I'm saying this is quality of life is different for all of us. Some people, quality of life is being able to go to Harvard Med School for their kids. Some people define quality of life as being able to love, have sex, and put pepperoni on a pizza. Investigate, be curious, do not be judgmental. As Ted Lasso said, for anybody who watches that series, be curious. Learn what it means for your family, that family that you're taking care of, what quality of life means for them. Leave your bias at the door. Next slide. So what do we know? Emerging medical and psychosocial evidence suggests that nuanced and individual approaches to perinatal palliative care are warranted for babies with life-threatening or life-limiting conditions. A one-size-fits-all that we have learned in medicine no longer works. Next. So this is an example of when you see these patients as they get older, what we do when we meet them for the first time when mummies are pregnant and they're diagnosed with these conditions that you see later in life. So the following is a case study that is de-identified amalgamation of the experiences of several of our families here at Capulani. Next slide. Anna is a 28-year-old gravid 3 para 2002. For those of you who have forgotten what that means, this is her third pregnancy and she has 2 live children at home. Her fetus was found at 18 weeks to have trisomy 13 and they confirmed it with an amniocentesis. After meeting with a genetic counselor, Anna and her husband Jay considered the option of termination, but after considering their spiritual beliefs and values, they opted not to terminate. On ultrasound and fetal echo, multiple anomalies were identified. Anna and Jay met with the cardiologist about their baby cardiac issue. Next slide. And what that meant for her survival and quality of life. The cardiologist told them that for cardiac surgery, if it was to be done, she will have to go to the mainland. Anna and Jay thought about this and then they decided to focus on comfort and was referred to us in the clinic. Next slide. Referral can come from anybody. If it is that you have, anyone who's pregnant and is going through a hard time, and have gotten just a really bad fetal diagnosis, you can refer to the clinic, the pediatric, to the neonatologist, myself, and the palliative care physician, and we see them jointly, or I will see them. And who we get referrals usually from are MFM physicians, genetic counselor, any other specialist, and it could be even requested by the family. Ideally, before we see them, the families have to have seen all of the consultants. If they have a renal issue, they see the nephrologist before. If the fetus has a cardiac issue, they see the cardiologist before seeing us. Next slide. And then what we do is we sit and have a goals of care discussion with them. And in that discussion, and when you're doing that discussion, coming out of now the sphere of perinatal palliative care, but just any palliative care or any discussion that you have with a family on the floor or in the PICU, when you're having a goals of care discussion, these are some tips. You want to be able to find out the family's prognostic awareness, their hopes and worries, and looking at future expectations. Use open-ended questions. Ask them, what are you hopeful for? What are you worried about? And I'm one who loves to talk. So give yourself some time in your brain to start counting down, to give that family a moment of silence to be able to speak. You want to find out the family's understanding of potential disease trajectories and outcomes, the family understanding of treatment options, the implication that these medical choices will have on outcomes. Sometimes when we decide to do a medical intervention, it may not change the outcome. The family's beliefs, values, and views of quality of life. The only people's view of quality of life that should matter in that room is the family, not ours. How family envisions spending the time that they have with their baby. Next slide. So Anna and Jay met with us, the palliative care and neonatology jointly, and about the goals of care for their daughter. They understood that their daughter, Dana, might not survive pregnancy, might not survive delivery, and if born, would not likely survive more than a few weeks without significant medical intervention. The decision of comfort care was a hard one, but they decided to make it at the time of birth for Dana. Next. The couple expressed that they were hopeful to meet her. They didn't want her to suffer. And if it is that she was stable enough, they'll take her home with hospice. They did request, though, assistance with age-appropriate explanation of Dana's condition for their siblings. And that's where we involve child life. And I'll tell you, I've been in a room where I thought that, you know, as physicians, we're like, we got this. So a baby was passing and had passed, and the sibling was holding the baby. She was 5 years old, and the mom said, you know, your sister has gone to heaven. And then the 5-year-old looked at her and said, well, where are her wings, mommy? And then she looked at me and I said, I don't know where to go with this, to be honest. So that's where it's really important to try to, when it is that you're dealing with these situations, to try to involve child life earlier rather than later. And culturally, some people may not like someone talking to their child. So you may want to just offer them, maybe you can talk to child life, and then that gives you tools in your toolbox to speak with your child. Next slide. So Dana was born via normal vaginal delivery at 38 weeks. At the time of delivery, she was able to take breaths on her own, and she was alert. She was held skin to skin with her parents. She was briefly able to latch and suckle. And her grandparents were there, her siblings were there. After about 30 minutes, she developed some increased work of breathing, and her RN gently suctioned her upper airway and helped reposition her. Next slide. Over time, Dana's respirations became slower and further apart. The RN showed her family how her breathing pattern was changing and let them know her time may be short. Dana died peacefully in the presence of those who loved her the most. Next slide. So the next poll question is, what are the risk factors for parental separation within 7 years of birth of an infant at less than 35 weeks gestation? Each of you have taken care of a preemie, yeah? At least once. So what do you think is a risk factor for parental separation within 7 years of birth of an infant at less than 35 weeks gestation? A, low gestational age. B, non-optimal neurodevelopment at 2 years. C, low socioeconomic status. And for those of you who don't know, any baby leaving the NICU, the parents have a greater than 50% chance of separation. All right, in the chat, do we have any takers? All right, Lanice says B. Choose all that apply. You can choose more than one. I see Grace said C, okay. A and B, all right, good. Okay. All right, any other responses? Okay. Sarah says C, okay. We'll come back to that answer. Hold on to it. So let's talk about neonatal palliative care. Next slide. So neonatal palliative care supports a family's hopes for providers to be truthful, helpful, provide meaning, safety, promote family strengths and harmony, and provide perspective regardless of the medical outcome. And I want to stress that word trustful. Sometimes we feel that in holding back from the parents that we're protecting them, but omission is not necessarily trustful. Next. So again, palliative care, neonatal palliative care, perinatal palliative care in a child. It is an interdisciplinary approach, team approach, focused on communication and planning goals of care with the families, specific to each family's individual, emotional, spiritual, and cultural needs. We aim to support the dignity and best interests of this vulnerable population in the NICU. We support parents and family. That's why we have family-centered care. But guys, I think what we forget the most is we forget to support each other. Sometimes after a family meeting, you're like, oh my gosh, I need to have like coffee. Or, you know, you're thinking about the wine that you can have when you get home or the beer. And that means that because to show true empathy, which we'll talk about, you have to be in the emotions with that family. You have to help them carry their burden. And sometimes that's a lot to give. So don't forget to lean and support each other. Next slide. So in 2019, 66.1% of infants' deaths occurred in the neonatal period. That's according to the March of Dimes. Birth defects, prematurity, low birth weight, sudden infant death, maternal complications of pregnancy, and respiratory distress syndrome remain some of the leading causes of infant death right here in the US. So I have to give you some stories. Sorry, guys, I'm not here to make you cry today, but I just wanted to make the presentation relevant. So on Sunday, October 21st, 2018, Vitea was born. She was a precious gift to her parents at 22 weeks gestation. If you can look in the incubator, she's covered by plastic. You all have been there on the warming mattress. You could barely see her because she's so tiny. And her mom is holding her little hand before they take her away from the C-section. When she left the NICU, that's a photo after. You can always tell the NICU babies, especially those 22-weekers that had retinopathy of prematurity, they were wearing glasses very early in life, but she's cute as a button. Next slide. Let's talk about Sophia. Sophia was born with, anybody knows what that is? The condition on the left. I'm giving you
Thalassemia.
Okay, omphalocele. Perfect. If you notice her face, her parents are holding her in the NICU. Do you notice her face there? You can see that she's intubated. Doesn't her face look very big? That was a critical night for those parents. And as physicians, we went in there and we spieled the medicine to them. We told them, oh, she's not peeing, she's not doing this, she's not doing that. And then I went in and they said, Dr. George, should we be worried? And I said, yes. I said, I'm not sure if she will survive the night. If you are praying people, you need to start praying. Next slide. But she did. Oh boy, did it take a team to get her home. And I know you guys are accustomed to this sometimes on the floors. It took the parents, the PCP, the palliative care team, the complex care nurse, case management, bedside nurses, respiratory therapists. It took everybody at the table to get Sophia home. And I will tell you that there's something about the people here in Hawaii that you can't get anywhere else. And I was so surprised to see that Sophia lived a little far, and we had problems getting home nursing for her. So do you know what happened? Some of her primary nurses, I've never seen this in my training, took on a second job to be able to be Sophia's home health nurses. It's for her to be able to get home. Next slide. So I asked mom to share her journal because she always journaled. That was her way of coping. You know, sometimes as physicians, we're so scared when parents write a lot. When you're in the room and they're writing on every single word that you're saying, and we're thinking, oh my gosh, are they thinking about lawsuit? But sometimes that's a parent's way of being able to cope. We have taken away all of their control. So what this mama said, this is what she wrote in her journal on the day of discharge. Sorry about the noise. My biggest one in a life throws you curveballs. Within the last 20 months, my focus, my heart was in hospitals. 10 months of intensive care units and even more in hospitals. 2 months ICU with my dad before he passed away. Believe it or not, I did not know that her dad was in the hospital until I read this. 8 months NICU with my first baby before finally being discharged. 265 days of being pushed to and over the limits. Next slide. Exhaustion, devastation, hopelessness, isolation, grief, loneliness, worries, depression, anxiety. Us turning into medicalized robots. That's us. That's everybody on the day of discharge. This is Sophia leaving with her trach on a vent and her feeding tube. Next slide. So the answer is, good job, everyone. Non-optimal neurodevelopment at 2 years and low socioeconomic status are the major risk factors for parental separation within 7 years of birth of a preemie. Next slide. So who will benefit from a consultation? Well, Carter et al. Said those born at the threshold of viability, meaning 22 weeks, 23 weeks, and 24 weeks, or who are similarly vulnerable by virtue of prematurity, those with birth anomalies that may threaten their vital functions, those whom intensive care has been appropriately applied, but now burdened with interventions that no longer are deemed beneficial, but come to be seen as burdensome, inappropriate, and only prolonging death. Next slide. There are guidelines published by the National Institute of Nursing, the National Association of Nurse Practitioners, the National Perinatal Association, the National Association of Neonatal Nursing, the National Hospice and Palliative Care Associations, and the Center of Advanced Palliative Care that speak to these categories and potential triggers for a neonatal palliative care consult. Neonates require end-of-life care or palliative care and medically complex patient, according to Walsh et al. In 2017, are some who would benefit from a neonatal palliative care consultation. Next slide. Samuel et al., they published end-of-life care in a regional level 4 neonatal intensive care unit after implementation of a palliative care initiative. And what they found, the benefit was that the implementation of a neonatal palliative care initiative was associated with increases in palliative care intervention for neonates in their final 48 hours of life, suggesting that such an initiative may enhance end-of-life care. So basically what this means is the earlier palliative care is involved, the better the care of the patient. Next slide. What they also found, Welsh et al. Found that improving care collaboration for the NICU patients to decrease length of care, stay, and readmission rate. So basically, they held weekly multidisciplinary meetings to coordinate and provide continuative care for medically complex patients in the NICU, and that was associated with improved patient outcomes. So again, involving palliative care early along that journey helps improve patient outcomes. Next slide. Perigo et al., they published a unique model of neonatal palliative care delivery. And they found that certain patients with complex medical or psychosocial problems were identified as needing expanded palliative care support early in the hospitalization course. Recognition of palliative care as more than exclusive end-of-life care provided time for families. Parents expressed gratitude and trust with palliative care interventions. Staff were highly engaged and continue to advocate for consults. Next slide. Conway, Orgal, and Edlund conducted a 10-year cohort study. And what we realized that in medicine, when you're trying to initiate anything, there are benefits, but boy, are there challenges. And what they found is they did a study that examined those pediatric patients who would qualify for palliative care, of which only 4% received palliative care. So it means us as pediatricians, we have to do better. And they described the development of a new algorithm and program to deliver neonatal palliative care to neonates less than 28 weeks gestation, first of its kind to look at continuous provision of neonatal palliative care throughout an infant's NICU stay. They were unable to maintain finances and staff, document success, or collect outcome data just due to lack of physician buy-in and hesitation amongst nurses to initiate a protocol. Next slide. Very few NICUs have an established palliative care protocol and team. There's even less evidence for successful implementation of NICU-based palliative care programs. Quality improvement initiatives are not sustainable when clinicians are not where clinicians may not know where to start and may face organizational challenges in the design and implementation process. Next slide. So what are solutions? We have a multidisciplinary neonatal palliative care team. And when we mean multidisciplinary, you have to have physician champion, the palliative care physician and nurse practitioner, the bedside nurse champion, chaplain, and social work. And then we need staff education. I think a lot of times we as pediatricians and neonatologists, we feel like we can do it all. We have been trained to talk to families. We have been trained to deal with sadness and grief. At the end of the day, though, let's do it together. Involve palliative care early, because what happens is you don't stay on service. And some of our colleagues, let's be honest, some of us are really good at it, and some of us will tell you, I am an introvert. From the time that mom starts to cry, I'm like, oh my God, somebody hug her, right? Because that's not what I feel the most comfortable with. Having a palliative care team going with you on that journey with the family helps the family to have that continuity of care. As physicians change out, as comfort levels change with the care, and then information, just like pilots and the airline industry, the major problem in medicine will always be the root: communication. Where did the communication break down? Having a team that is constantly on that journey, you have now a resource for what has been said, for what has been discussed, and for expression of what the family's goals are. Perinatal involvement of a neonatal palliative care team. It's a source of support for the families in the NICU, and we get to know them before the families come. And then you just develop criteria and develop order sets to decrease variability in practice. Next slide. So the AAP in 2013, the American Academy of Pediatrics policy statement, pediatric palliative care and hospice care commitments, guidelines, and recommendations urged broader integration of palliative care into overall medical care plans, not only for terminally ill infants. Could you imagine? Your kid is dying, and then you have an extra team coming in to say, hello, how's life, right? And so we want to not only wait till they're terminally ill infants and children, but also for those with life-threatening or life-shortening illnesses. Next slide. The NAN Board of Directors in February 2015 also stated the same, right? That infants born with a life-limiting condition or who develop life-limiting conditions during their neonatal hospitalization may receive palliative care. It should focus on improving a patient's quality of life and may be offered concurrently with curative measures to treat symptoms, minimize suffering, and offer improved quality of life. Next slide. In 2017, the American Academy of Nursing published a policy that contained 6 recommendations regarding perinatal palliative care as a collaborative effort across several disciplines. Next slide. So, coming down to the end, is there a difference between empathy and sympathy? Are they the same? Let's see what the chat says. The chat is thinking. Not seeing anybody responding. Anyone? All right, I see A. They aren't the same. Thank you. So far, everybody says different. Anybody else? Is there anybody in the crowd that thinks they're the same? All right. Okay. We'll answer that soon. Let's look at this video. Could you click on the video? Sorry. Volume.
So what is empathy and why is it very different than sympathy? Empathy fuels connection. Sympathy drives disconnection. Empathy, it's very interesting. Teresa Wiseman is a nursing scholar who studied professions, very diverse professions where empathy is relevant, and came up with 4 qualities of empathy. Perspective taking, the ability to take the perspective of another person or recognize their perspective as their truth. Staying out of judgment, not easy when you enjoy it as much as most of us do. Recognizing emotion in other people and then communicating that. Empathy is feeling with people. And to me, I always think of empathy as this kind of sacred space when someone's kind of in a deep hole and they shout out from the bottom and they say, I'm stuck, it's dark, I'm overwhelmed. And then we look and we say, hey, you climb down. I know what it's like down here and you're not alone. Sympathy is, ooh, it's bad, no, you want a sandwich? Empathy is a choice, and it's a vulnerable choice, because in order to connect with you, I have to connect with something in myself that knows that feeling. Rarely, if ever, does an empathic response begin with at least. Yeah. And we do it all the time, because you know what? Someone just shared something with us that's incredibly painful, and we're trying to silver lining it. I don't think that's a verb, but I'm using it as one. We're trying to put the silver lining around it. So I had a miscarriage. Oh, at least you know you can get pregnant. I think my marriage is falling apart. At least you have a marriage. John's getting kicked out of school. At least Sarah is an A student. But one of the things we do sometimes in the face of very difficult conversations is we try to make things better. If I share something with you that's very difficult, I'd rather you say, I don't even know what to say right now. I'm just so glad you told me. Because the truth is, rarely can a response make something better. What makes something better is connection.
Thank you. Next slide. So you are right, there is a difference between empathy and sympathy. And for your toolbox today, to help to give you a few items for your toolbox, I'd like to suggest that when we're having these goals of care discussion with families, avoid saying, I'll never say at least. There is nothing that you can say to make any situation that is damning and awful better for someone. All you can be is to sit in their pain with them. Avoid saying, I'm sorry, before a child or an infant has passed, because you make it about you. Try to keep it about the family. And that is the end of my presentation. Any questions? And then for Maya, just to circle back, how to address fear of palliative care, what I tell, because I've had to help the neonatologists, also my colleagues who are very good, be able to address it. What I tell them to say is, when you look on Google, palliative care is about death and dying. We're not talking about your child dying. What we're talking about is just that we want to make sure that you have an extra layer of support through this very difficult time. They're going to be a continuous support system for you during the hospital stay and even after that stay.
Thank you. One of our participants, Sarah, also said, thank you. That was a wonderful presentation on this topic. I guess I would love to follow up on that. You say we're not talking about your baby dying, but sometimes we are. And I think that a lot of times we as healthcare workers fear that. Like we fear it in so many visceral ways that are hard to articulate, and certainly that don't belong in a conversation with a family, but might still affect our actions. Do you have any tips for us how we can try to be like deeply empathic and compassionate and present while taking ourselves out of that? Do you know what I'm saying? Like it sounds like a contradiction, but it's not.
Oh, it is. And I struggle with it, right? Because bias, sometimes you will say, like I was when I had my nurse practitioner mentor, she sat with me in one family meeting and I thought, oh, this family meeting is going really well. I'm getting the parents to do comfort focused care. And then when I left the meeting, she said, Kandie, your bias showed. So what I try to do is recognize your bias. Before you go into that family meeting, call your bias out to yourself, right? And then once you've called your bias out, every time it starts, like your experiences, your cultural experiences, your own lived experiences, start to seep into that conversation with the family. Hold yourself back. Doing open-ended questions where you're doing a lot more listening than talking helps. And then you can ask questions like, and then try to, when you're listening more, you can now find little things that the parent may say that you may be like, oh, wait, they may be wavering too, because most times they are. And then you can latch onto that and say, I heard you say this. Could you tell me more? And then when you want parents, we think that they don't get it. 10 people have spoken to them and they still come in happy into the hospital and their baby is dying or their child's dying and they still have a smile on their face and they're not crying or sobbing at the bedside. And we're like, they just don't get it. But they do, because you know what's the only thing that had brought them to the hospital and woke them up that morning from bed and gotten them out of bed is hope. So don't think that because they are not mourning in their sadness and rolling around on the floor means that they don't get it. Statements that may be helpful is, I wish that things were different. I wish statements are beautiful statements. I wish things were different. And never use but, because when you use but in a sentence, practice with your spouses and your friends. When you use but, your significant other has heard nothing before but. All they hear is, you'll be like, oh, I'm so happy that you cleaned the garage, but you didn't do the dishes. I will tell you that in that conversation, the only thing they will hear is that you're ungrateful and you didn't do the dishes, right? So you say, I wish that things were different, and we worry that we may not be able to save your child.
Thank you.
Is that?
No, that's great. I don't think I thought about the difference between and but, and that's a really easy tip to follow and I think really meaningful. Looks like Summer has just started the poll. So for those that want continuing education, go ahead and fill it out. Actually, for everyone, if you would, then we can also just make sure to see how, if there are any that were not clear, that we can ask Dr. George to go over. I wanted to announce that next time we'll be having Dr. Jennifer King to present. She's one of our sports medicine docs, and she'll be talking about dance medicine or overuse injuries. So if you have a preference, let us know if you feel strongly about one or the other. And then the last thing, announcement housekeeping wise, is that we've gotten some feedback outside of this forum from folks in the community that 12:30 might be a better time than 12 o'clock, especially for those in an office-based setting where lunchtime might be a little bit later. So this is a one question survey monkey in the chat. If you all could fill it out, we would really appreciate knowing what you think about the possibility of changing from 12 to 1 to a 12:30 to 1:30 slot. It would still be on the same day and the same week of the month. So please click on that link in the chat box. Looks like for the poll, we have just a few answers. So far, for question 1, anybody still working on it?
Everybody should ace it because Dr. George went through it.
Yeah.
Good practice.
Okay, so we have 5. Maybe we can just give it like another 10 seconds or so and then go over the answers. Dr. George, you can see the poll as well.
I can. Thank you
Okay.
so much. So fancy. Does anyone else have any questions or no? Okay. I do recommend if anybody is interested in how to communicate better with these goals of care discussions, the Vital Talks is really, really good. And I thought it very helpful.
Thank you. So post-session questions, number 1, what percentage of those women who choose to continue their pregnancy knowing their fetus has been diagnosed with a life-limiting condition did not regret their decision to do so after the birth? And the correct answer is D, 97%. So that we talked about that quite a bit. What are the risk factors for parental separation? In this one, we had one person who wrote low gestational age and everyone else selected non-optimal neurodevelopment at 2 years and low socioeconomic status. Do you want to just clarify that one a little bit, Dr. George?
So lower socioeconomic status and poor neurodevelopmental outcomes are definitely linked to parental separation. And it may just mean because of low resources and the amount of care that will need that a kid, a child, or an infant, or an adolescent with a disability has can take a toll on the family.
Great. Third one, is there a difference between empathy and sympathy? It was a great video, but I think we got all of us got the question right. And then palliative care is a active and total approach to care during a child's illnesses, focusing only on pain management, advanced care planning, and discussions of end-of-life wishes. And while those are definitely part of the conversation, I think you shared really beautifully how palliative care now is so much more than that, and how it focuses on so many other aspects of what patients and families need before, during, and after the time of death, or just in the case of a life-limiting illness, right? Okay, great. And then for everyone, thank you. There's several more thank yous in the chat, so I appreciate that. And then for anyone who hasn't done the Survey Monkey, please let us know what you think about changing to a slightly later time to start to facilitate more participants.
Thank you so much, Dr. George. Dr. George's slide deck is available for you in iEcho. I don't know for some of you who are aware of the content glitch iEcho had. If you attend Behavioral Health Echo, you knew about it, but they fixed it, so it is available for you on iEcho. Mahalo.
Yeah.
Or
thanks,
the
George.
talks. I will try to I'll send it to Summer, the link, because I'll have to Google it at the moment. You're very right. It is a very good, I should have had the link available. Thank you.
Yep, you can send it to me and I'll share it on iEcho with everyone.
Awesome.
And I can text it to you if Summer sends it to me, because we have each other's cell phone numbers, so that'll be great. Thank you. This was a really wonderful talk. I think just such an important topic, even for those of us that are not in the NICU. Really, like you said, very relevant and applicable to lots of different situations. Thank you.
Thank you for having me.
Bye, everyone.